Good afternoon and welcome to Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about recent changes to survey guidance. And now I would like to introduce our industry guests for this episode. We have Sharon Harder, Board Chair and President of C3 Advisors, LLC, on the call today. At C3 Advisors, Harder oversees all home health and hospice client projects, the majority of which are focused on compliance issues, including scheduled Medicare, Medicaid compliance audits, acquisition due diligence, preparation of responses to investigations, and labor compensation issues. And we also have Nanette Minton, RN, HCS-D, HCS-H, HCS-O, OC board member and senior clinical coding manager with Mac Legacy on the call today. Nanette has served in leadership capacity for over 20 years, holding a variety of roles in the home care and hospice industry, including clinical, administrative, consulting, education, and agency startup and development. Thanks so much for joining us today, Sharon and Nanette.
Thank you, Jan.
Glad to be here.
Let's get things started with an audience poll. I'm going to get that launched. All right. And our question, which is for you today, is which of the following documentation related survey issues do you have the most trouble with in your organization? And our answer options are individualized plan of care, comprehensive assessment, medication regimen review, transfer and discharge documentation, or patient receives written documentation of the care to be provided. And I see folks are still submitting votes on that. So please choose your answer from that list and we'll discuss the results a little later on in the call. And if you have an answer that you don't see on that list, feel free to share a comment in the question pane and we can also discuss those when we look at these results. All right, it looks like voting is slowing down. So I am going to go ahead and close the poll and we will discuss these results a little bit later in the call. All right, let's get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane and we'll try to get to as many of those as we can. Before we get on to the main topic today, we first have a look at the upcoming proposed changes to the ICD-10 code set. The inpatient proposed payment system proposed rule has been released and it offers an early look at what might change for diagnosis coding come October 1st. Nanette, what could be on the horizon for coders in fiscal year 2025?
Thanks, Jan. I appreciate it. So one of the things we're looking at, and again, these are proposed, so it just depends on whether or not they're going to implement these things. So there's more than 250 new ICD-10 codes proposed. And one of the ones that's really interesting is an update to how we're going to classify hypoglycemia. And so they've broken that down from just like an E16 code. We've got E16A1, 2, and 3, where a level 1 would be your the blood glucose concentration being less than 70 milligrams per deciliter as an alert value to help individuals avoid more severe hypoglycemia. And then that level 2 is less than 54, and it's usually when the patient is having some neuroglycopenic symptoms begin to occur. In other words, they are having trouble thinking or focusing. And then definitely level 3 would be a severe event characterized by altered mental or physical functioning. This is where you would come in, maybe find somebody who was not alert with such a low blood sugar. And it can occur. We usually think of this being only a type 1, but certainly type 2 diabetics are affected by this as well. So it's kind of interesting. And I think probably, as we become more granular and more educated in the healthcare industry, it just, the coding is going to follow that, which coders are going to then have to look at more documentation. So, and then also there is a new code to capture patients who are pre-symptomatic for type 1 diabetes. I don't know, Jan, if you don't mind,
Oh, did I?
Thanks. Yeah.
Oh,
No,
okay.
we're good. We're good. Thank you.
Okay.
And so just looking at that, again, it'll be interesting. We're going to have to look at all of that documentation and, try to determine where we're at on that. And then, again, I always say that it takes a couple of months once these things pass for us to be able to look at what actually, happens with these particular codes. So we will see what happens with that. And if we, move on, thank you. There's also, and I find this quite interesting, a code for sepsis aftercare. And it's kind of interesting that the thought process here, because many times it's kind of like you're faced with somebody who has a severe event. They've been in the hospital maybe, multiple weeks, lots of things going on with them. And then what happens is, guess what? They're no longer septic, but then they go home, but they're weak and they have so many other symptoms. Maybe they're still on a little bit of an oral antibiotic to finish out the residual of that infection. But again, their sepsis is resolved. So we really shouldn't be coding that active septic event, but that's what we end up coding because it most likely it's the thing that represents what's happened in the hospitalization. And all of those, it flows to the billing, and it flows to we're not going to get paid if we're not documenting what, the reason for the care. So anyway, it'll be interesting if that passes and how we'll look at that. Also, F50.2, they're expanding the eating disorder codes. And so they're just really defining bulimia nervosa, mild, moderate, severe, extreme, and in remission. So kind of something that we will be looking forward on that. And then you will see they're going to be updating some of the musculoskeletal and connective tissue codes. I did not list all of those out here, but so updates to intervertebral disc degeneration in the lumbar region and lumbosacral region is going to be replaced by 7 new codes based on whether that pain is discogenic and having pain in the lower extremities, or no mention of either type of pain. So definitely something to look at there. And obviously we'll do lots of education from my end once we, if all of these things are approved. And then once again, they're really looking at social determinants of health. We know this is something that the health industry as a whole is really looking at health equity, quality, and how this affects the care that we're providing. And so they're expanding Z59.7 into codes for insufficient social insurance or insufficient welfare support. And so we'll get into that for sure. And one of the things just to keep in mind with those social determinants of health, we wouldn't just add those to the plan of care willy-nilly. We would need to have documentation of how that is affecting that plan of care. So.
Great. Thanks so much, Nanette. All right, now we will move on to the next topic we have for today, and that is to take a look at CMS's release of updated survey guidance. This was released on March 15th, and it's the first significant update for state surveyors of home care agencies in several years, and the changes were effective immediately. So Nanette, I'm going to turn it over to you to walk us through the highlights of these changes, and then Sharon can join us along the way for some discussion.
Okay, that sounds perfect. And so I've included the link there in case you've not had the chance to do that. And as Jan said, these were released on March 15th, became effective immediately. I didn't go into a lot of information on the education for surveyors, but obviously that's a big part of this, is they would require the surveyors to go through this education. And, you know, the whole goal is that, you know, one of the things that they're really trying to do is retire, you know, they're going to retire all of these CMS memos that are no longer applicable or that have been incorporated in Appendix B. Going to really look at the survey protocol for home health agencies to be a part, to make those part 1 of the Appendix B, replacing some of those. So they've done a lot of consolidation. So Jen, if you want to go to the next slide. Now this slide says G tags, probably should have just said tags, but there are going to be fewer available G tags. Now they've combined them. Remember, they're not removing or deleting any of those, but they're just trying to provide and consolidate information based on data that's been, information that has been out there, and really revamping that. Their survey procedures are also being incorporated into the tags. And so the goal is to provide the surveyors clear instruction on how to assess all of those, and enable the agency to better prepare for surveys by understanding the specific approach those surveyors will take. And so that's definitely a good thing. So one of the things is they did the level 1 standards and associated tags were revised. They did add 3 emergency preparedness tags that were added to the level 1 standard. I didn't include a lot of information about that. And then they just understand that they actually eliminated the level 2 standards, and that a partial extended survey is going to be triggered when non-compliance is found in any level 1 standard. So, okay, sorry, Jen, I've spent extra time on that one. Okay, so they did update not just this language, there were other language that was updated throughout, but particularly the one that we looked at is allowed practitioners. So there were language updates regarding that, just trying to, you know, make sure that we're all using the same language. We know that's what we're using throughout, because we know other practitioners are allowed to be in on that plan of care. So good to have that. And let's see. All right. So I mentioned this is something to really be aware of. So the addition of a statement, this statement was added to several COPs. And so you know, they added it to several of the tags. And just because I do want to state, just because it's not there does not mean that that particular issue could not escalate to a condition level deficiency, but you know, as identified by that surveyor. But it would make sense that the tags with this specific statement will most likely receive increased attention from the surveyors. And so this statement is: the manner and degree of non-compliance identified in relation to the standard level tags for this condition may result in substantial non-compliance with this COP requiring citation at the condition level. So just be aware of that. You know, I always feel like as I'm preparing for a survey, which should not, that should be a continual thing, that you have monthly you know, meetings with your, you know, leadership staff, and you're constantly preparing for this. It's not something that you do once survey is fixing to walk in the door, because they could walk in at any time anyway. But again, to maybe first focus on those things and utilize this guidance. Okay, let's see. So one of the things too is just, you know, surveyors, infection prevention and control, we know from COVID and all the things that we've dealt with, is a huge issue. And they're going to be looking to ensure that agencies have stated their source of, you know, what source are they using to implement within the agency that infection prevention and control, and why that one was used, and how it best fits with the practices of the agency. So just make sure that you have some information, like if you have an infection control book, that kind of thing, that you have all of that cited and can be prepared to speak to that. Okay, so care planning. We want, this is kind of interesting, that, move here in my notes. So previously, and I think this is super interesting. So previously, diagnoses were required for every ailment that the patient had, which could sometimes result in an extensive list of 30 to 40. And it's crucial to grasp that the interpretive guidelines really direct surveyors to review the chart, ensuring inclusion of all pertinent diagnoses with the focus of those more closely associated with the home health current plan of care. Now, so let me not create any confusion. We are still going to need to ensure that any diagnosis that has of clinical significance that has the ability to affect the plan of care is captured and is addressed in some manner. Now, this doesn't mean you need a goal or an intervention for every diagnosis, but it does mean that at some point, maybe upon admission, the clinician acknowledges, and as well as ensuring that you have appropriate documentation to back up the fact that that's a valid diagnosis with a assigned history and physical or some kind of backup documentation in your chart, which is something you should have anyway to verify the coding. And then all medically necessary supplies and equipment for the patient's care must be included. Now, if the patient's wheelchair, walker, crutches, and canes, whatever equipment is in the home and it's been there for 10 years, it sits in a corner and they don't use it, then those things are not going to be listed on the plan of care. So it should be something that's currently incorporated in that particular plan of care. Okay, comprehensive assessment. And I think this is something you probably want to spend a fair amount of time on. If you have not, is looking at the new interpretive guidelines regarding any discipline involved in treating the patient, whether skilled or registered, is permitted to review the medication profile. And I know with a lot of agencies using therapists to do admissions that, this is a good thing that this is clarifying how this is being utilized. Now, some of those clinicians may not be comfortable with that. There may be some education, and you may have to look at within your agency to determine what's going to be best for your agency. But again, there's quite a bit of information on this, so you would want to be sure you look at a policy you have, the skill level of the clinician, and licensure and all of those things to determine how you're going to handle that internally. And I think that's most of what I had to go over. If Sharon, you want to jump in on anything here?
Sure. Sorry, I just had to unmute myself. Well, Nanette, you did a great job with this. And I would just add that I think this is sort of part and parcel of an ongoing effort by CMS to get things to the point, particularly surveys, to the point where there's more consistency among the state organizations. So, I've been around for a long, long time. Back in the good old days, all they did was they came in and looked at our policies and then they left. Now, of course, the surveyors are much more focused on charts and patient care and the conditions of participation as they were changed in 2018. But we've still had vast differences among and between states and state survey organizations as to how the surveyors are conducting themselves and what they're looking at and how they are drawing conclusions with respect to the documentation that they're seeing. I think this is CMS's effort to tighten this up so that surveys are going to be more consistent from one state to the next. And of course, they're going to pull in the accrediting organizations who will in turn sort of up their minimum guidelines as well. And the other thing that I think is happening here, and we've seen it in practice with surveyors and over the last 4 or 5 years, is that they are now inching outward with respect to some of the things that they're looking at. For example, in chart reviews, I've seen surveyors now commenting on the dates on which orders are being signed and a lot of other things that have historically been the province of the payment side. They weren't really looking at, is the order signed and when was it signed? Lately, they're doing a lot more of that. And I think that's because CMS has a longstanding expectation that surveyors are going to be the people with boots on the ground. They're going to be the ones that are going to come in and basically eyeball the manner in which the organization is operating. And when they find concerns, they're not necessarily charged with investigating those, but they are charged with communicating to others their concerns if they have them. And that's really should be a big focus of this. It's not just the conditions of participation, it's also the conditions of payment. And they're starting to kind of bring those together, even though they're different, bring those together a little more and get a more coordinated approach to all of this. And so we need to take it seriously.
Thanks, Sharon. And thanks, Nanette. This is really helpful and hopefully will give folks some idea of what to expect, as things move forward. Let's take a look at our poll results because I think they relate to some of the changes that Nanette walked us through. So we asked folks which of the following documentation related survey issues you have the most trouble with in your organization, and we have a tie at 33% each for the medication regimen review and the written documentation supplied to the patient of the care to be provided. So Nanette and Sharon, what do you think are the issues that make those tricky for agencies? And do these changes to the guidance offer folks any ways that they might start to get ahead of these issues? Or is it something they're going to see even more scrutiny of?
Well, I think so. Thank you, Jan, and I would agree. I wouldn't disagree with that. It's really interesting. Medication regimen review is just something that now we have the updated information, and I think it just falls back to what is your process within your agency, and if you don't have a good process, who's going to do that? Who's initially going to help? Is there support in the office for the field? Are we ensuring that, any adverse effects or, things that need to be notified, the physician needs to be notified of, are those sent off? Are we keeping an updated med list in the home? Some of the things that seem rather old school, but again, it boils down to those process measures and inspecting what you expect as well. Regarding the written documentation of care, and this is a struggle all across the board. I work with a lot of agencies on pre-claim review, and we're now seeing, even in that plan of care, if they're not clearly understanding what is medically necessary on that plan of care, they're denying it. If they can't see just because you have a few goals and interventions, they have to see something that shows medical necessity. And so I think every time we document care, we have to really hone in. And I think we can't just say it to clinicians, we have to provide examples. What do you mean by that? That means that you have to document your teaching, the specific wound care, how the patient managed how they tolerated it, what's the plan for the next visit, what did it look like? I mean, there really has to be, you have to fully understand if this visit was the only thing that I was able to show to Medicare, indicating that the patient qualified for home care for a skilled need, it would need to stand by itself. And again, it's an education. Where, you know, staffing issues. I mean, I understand all of the things that are happening within agencies, but again, it goes back to your process. So, Sharon, I'm sure you can add some additional things to that as well.
Well, I'll just add one quick thing because I know we're getting toward the end. But you know, Nanette, you talked about review choice, and your point is very well taken. I spend a lot of time on the other end of things when claims get pulled out for review. And one of the things that strikes me is that we will see all kinds of interventions and goals in the plan of care, and virtually not one word about 80% of those interventions and goals in the visit notes that we're reviewing. And when that happens, the outside reviewers, reaction to that is, well, this could not possibly have been medically necessary. They only did one thing while they were in that patient's home, and it was wound care, and the patient or the caregiver was already documented as being very able to provide that wound care because it wasn't on a part of the body that wasn't accessible or viewable. Or we've got teaching now going on for 6 certification periods in a row, and it's the same teaching on the same meds and the same disease processes. So I think it's important that we need to establish medical necessity in the plan of care, especially for the survey review. And we also then need to follow up with documentation that talks about what we're doing about that, how the patient is reacting to it, and that documentation needs to meet all the standards that they've so nicely outlined for us in Chapter 7.
Thanks so much, Sharon and Nanette. That's really helpful. And thanks to everybody for who participated for taking the poll today. All right, we just have a few more things to wrap up before our call is done today. And now it's time to share what's new with AHC. And that's the segment of the show where we share updates from the Association of Home Care Coding and Compliance. If you hold a Board of Medical Specialty Coding certification, our credential holders survey is still live, and we would love it if you would hop over and tell us what your certification means to you and how we can better serve you. So you can follow that link in your handouts to take this year's survey. And if you haven't downloaded the handouts as part of the live call, you can find them on the AHC website under resources and then free webinars after the live call. And we also wanted to share a little product spotlight during this episode. If you're interested in learning more about the changes to survey guidance and other issues that impact home health, you might want to subscribe to the Post-Acute Care Loyal Listener Library. This is a webinar library that will help you to stay up to date with the latest changes from key home health rules, OASIS and coding updates, and new survey guidance. And subscribers to the Loyal Listener Library have access to a new webinar each month, as well as dozens of on-demand events. Recent coverage includes face-to-face best practices, how to set your agency up for financial success, and home health value-based purchasing lessons learned and best practices. And you can follow the link in the handouts to learn more. And for a limited time from May 20th through May 27th, you can get 40% off on the Loyal Listener Library with the coupon code AHCC40. So if you're interested in that, now's a great time to subscribe. We hope you enjoyed this episode of AHC Talk. Thanks to Nanette and Sharon for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our next call on June 17th, when members of the AHC board will be discussing cardiac coding issues. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can now find AHC Talk on your favorite podcast app. And if you have any suggestions for future guests, topics, or ideas about the format of the show, you can always send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. Thanks to our panelists, and we'll see you next month. Take care, everybody.